Hi, my name is Alan Gonzalez-Cota. I'm a board-certified anesthesiologist with a specialty in pain medicine, and I'm the consultant for pain medicine at the IAFF Center of Excellence for behavioral health, treatment, and recovery. Between 1992 and 2012, the utilization of opioids in the US tripled when the population did not. So that was a very interesting phenomena. And studying the roots of the opioid crisis, we have several factors. One of the main ones is the pharmaceutical industries. They really promoted opioids as a safe alternative based on a few studies of low quality, meaning case series, where they saw that a few patients did not got addicted over a few months to these medications. And so that in addition, there was a big push on the Joint Commission to incorporate the fifth vital sign that came out from the American Pain Society as one of the evaluation methods of pain, and just a number from 0 to 10. And as we all know, this was widely used over the last 20 years and was used as a tool to know what's the pain level of the patients and the response to the opioids. When we know on psychological studies, that's probably not appropriate. So if the patient had a 10 out of 10 pain, I will treat it with a high dose opioid, and that incur into some addiction. And these patients really became dependent on these opioids even when their pain resolved. In addition, the US system, it's a fee for service, unfortunately, and large healthcare systems are incentivized to keep the patients in their pool. And one way is to open pain clinics and track these patients and be opioid based. So there was a lot of push on productivity for physicians to maintain the patients in the system, consuming multiple MRIs, unnecessary procedures, in order to continue their opioid medications. So to summarize, pretty much physicians and the government failed to protect the population. Opioids are okay in some instances, such as acute pain from surgery or major accidents where the patient is admitted to the intensive care unit with multiple fractures. And the other indication is cancer and invasive processes and end-of-life care. Today, there's not a single high-quality study that points towards any quality improvement or functional improvements in chronic non-cancer pain. The difference between acute pain and chronic pain is that chronic pain is ongoing. It's like the alarm bell keeps ringing. Acute pain is when we have tissue trauma of some sort, such as a burn, a cut, contusion, and that contusion, burn, or cut will resolve over time, will heal, and then the pain resolves. That's the major difference. The big problem with chronic pain is that leads to severe emotional and physical distress, disability, and the main problem is that patients cannot go back to work or school or to their usual retirement activities, and they tend to isolate. So chronic pain is a totally different animal, and it's a disease by itself, recognized in healthcare professionals as its own entity. The standard definition of chronic pain is pain that persists over 12 weeks. And it's a good start point for the general practitioner and the general public. But it needs to be adapted to each patient. If a patient underwent major surgery or lost limb, then and they have pain for 10 weeks, I will accept that patient to become in the chronic pain category. some of the pain management issues that I see in the firefighters, they come in three categories. First is the non-traumatic repetitive use related pain, such as disc degeneration or joint degeneration, most likely from the type of activities are required to be performed, such as carrying high loads or multiple repetitions of the same movement. The second, less common category that I see is trauma-related pain, specifically when the firefighter gets a fracture and undergoes multiple surgeries, such as joint surgery or back surgery, replacements of joints, back fusions or neck fusions. And the third category that I see is patients that have predominant traumatic brain injury or post-traumatic stress disorder related pain, since the rates of these conditions are higher in the firefighter population. There is clear evidence in studies in preclinical settings, such as animal models, that if a brain gets exposed to trauma, generates inflammation. We call it neurogenic inflammation. And on the pain science side, we know that this neurogenic inflammation will lead to increase transmission of the pain signals. So if the firefighter had head trauma of some sort, and also a traumatic event like a psychological anxiety or psychological trauma, such as PTSD, we know they also develop this neurogenic claudication. And what happens is that we can get a pain trigger, such as arthritis in the knee or nerve damage, and the brain is just more aware of our environment. And what happens is that those pain signals are easily transmitted to higher centers in the brain, and that small arthritis level in the knee becomes really amplified in our perception system or conscious mind. So we call them pain amplifiers. The multimodal approach is a version of what we call precision medicine, meaning there's a very individualized treatment to each patient depending on their condition, their medical status, their age group, their cultural background. So the whole goal of this program is to minimize or ideally eliminate the reliance on opioids. And the first thing that needs to happen is to train the patient on this shift in mentality, where we typically in a pain clinic, we go for a symptom modifying process, meaning numbing the symptoms or trying to change the symptoms, versus disease modifying approaches in pain management, where we can correct a disc that is inflamed, a joint that is not functioning well. So there's a lot of rehabilitation medicine involved. So the main goal, as I stated, is to avoid the opioids first line. And if the patient's coming on opioids, it's fine. We can always taper. It's easy in the pain clinic because we can provide a alternative approach to treating pain in the name of a psychological intervention, behavioral medicine, alternative approaches, such as Tai Chi or acupuncture or transcendental meditation. First, if the patient is on pharmacological treatments, in the opioid category, we try to taper them off, or if they're not on opioids, avoid them completely. If they're on non-opioid pain relievers, such as nerve pain medications, anti-inflammatories, muscle relaxants, we try to adjust the doses and make sure there's no interaction with other health conditions or other medications. The second factor is aggressive pain control in the sense of interventional pain medicine. When we have those nerves that are very noisy and they're reacting from an injury or because there's joint that is very painful, and those pain signals are like traveling all the time up to the brain. We can do several procedures. An example is thermal coagulation, where we go ahead with a small needle under image guidance, and we increase the temperature on the nerve, and it stops working for about a year. All of this with the goal of the next tactic that we use is rehabilitation medicine, meaning the patient undergoes a customized physical therapy or occupational therapy plan very aggressively to retrain the nervous system back to normal. And lastly, and of high importance, is psychological interventions such as cognitive behavioral therapy to improve the functions of the brain, and so the patient copes better with the pain and have less fear of some movements that they might have or pick up over time. We call that kinesiophobia, which means fear of movement. And all of this to maximize the patient's well-being and their quality of life. If the firefighter is anticipating surgery, I will recommend talking to the surgical team, specifically to the surgeon who is going to operate, about non-opioid alternatives, which they come in many categories. Traditionally, pain after surgery is being treated with opioids, but we know by multiple studies that it's possible to treat pain without opioids. There are many tactics. There are medications that calm down the nerves. There are medications that disinflame. There are medications that will numb the nerves. There are also, this field of anesthesiology that is called regional anesthesia, where the trained anesthesiologist can go under guidance on the bedside before the surgery and put a catheter or just inject some numbing medication and pain relievers around the nerves that transmit the pain signals from the region which is going to be operated. It can be in the form of a plexus block, also a neuraxial technique. People know them as epidural blocks or spinal blocks. The other alternative is for the surgeon themselves to inject a long-acting local anesthetic. But the problem is, if the firefighter has a history of substance abuse or a different topic like chronic pain, or the patient is on opioids because they just had the accident, or they just had another surgery and they're doing staged surgery, then I'll recommend to talk to a pain specialist, or at the minimum, go to the pre-op anesthesia clinic. Every hospital will have one of this, where they can go ahead and do the planning before the surgery. And that way the patient can maximize the chances of being pain-free a few days after the surgery. For the CDC recommendations for an opioid taper that are designed to help the primary care community, first we need to know what are the indications for the opioid taper. One of the more important ones is if the patient is requesting the opioid taper, they don't want to be on opioids. That means the patient is either motivated to come off the opioids. The other indication is if they're not getting significant functional improvement of their pain. Our cutoff is at least 30% of pain improvement. And if they're not obtaining that, they should be weaned off opioids because the risks are higher than the benefits. If the patient had an episode of overdose, it's also another indication for weaning the opioids off. Also, if they show up in the clinic and they're frankly intoxicated and they're unable to perform well, the patient absolutely needs to be weaned off taper. So how do we do this taper? The most important part is to use a motivational interview explaining the risks versus benefits of opioids extensively. We call this informed consent in medicine, stating such risks as hormonal dysfunction, decrease of the immune system, loss of bone mass, muscle mass. All these things really trigger a response in the patient, especially if they're not seeing big improvement in their pain. We'll typically do, per the recommendation, a 10% reduction on a monthly basis. And from there, it needs to be adapted to the patient specifically. Of importance is to provide psychological support to all these patients that are being weaned off the opioids. And it's very important to refer the high-risk patients, such as patients with a history of any substance abuse or pregnant patients, to a specialist, so they can decide what's the best way to wean down this the opioid medication. And what is very rewarding is that patients are very surprised when we wean the medications to a therapeutic dose, meaning a low dose opioid type opioid use. And a lot of times when we wean the medications off completely, they're so impressed that their pain is much improved. This is related to paradoxical effect of the opioids, where they can induce pain. We call this opioid hyperalgesia, which means increased pain from opioids. Patients are often surprised of their functional gains and improvement of pains after we establish this taper. And what's of more importance is that lots of patients that are weaned off completely the pain medications, their pain improves significantly. And this is related to that paradoxical phenomena that happens with opioids. Opioids are not only pain relievers, they can induce pain too. And when the patient is off the opioid and they feel way better and they can be more clear in their mind and they can do their tasks better, they really feel that they are making significant improvement in the clinic. So this is very rewarding. If the firefighter is seeking for alternatives for pain management, I do recommend talking to their primary care about lifestyle changes. Speaking about sleep, their exercise ability, and the ways to control the stress are very important. There are many ways to do that. I strongly propose transcendental meditation, also combined with some sort of physical mind-body techniques such as yoga, acupuncture, or Tai Chi to improve the quality of life. I also recommend undergoing a training program online, specifically about pain, or they call them back pain schools. There are several of them online, and they can really enforce how pain and the pain sensory system of our bodies work. And if we're aware of how the mechanics of our nervous system are happening at any point of time, and that really will encourage the patient to use some of these techniques. The next alternative is to seek for corrective surgery. A good example is hip surgery. I'm the first one to call my orthopedic colleague that specializes in joint replacement surgery if I see somebody severe in their 50s or 60s. And many patients are afraid of undergoing the joint replacement because it has a lifespan of about 10 years. So they want to delay it until later in their life, like in their 70s or 80s, but I think that's not appropriate. I do recommend patients that have good indications for joint replacement surgery to undergo when they're highly active or they're in retirement, like in the 50s or 60s or 70s. I ask my patients, do you want to be in high quality of life in your 50s or 60s, or you want to be in high quality of life in your 80s or 90s? So that really triggers a response. And also, well, ultimately, if there's no corrective surgery or no corrective treatments, for the chronic pain condition. I do recommend to seek out to a reputable pain center in their community that specializes in non-pharmacological treatments, and that their physicians are board certified in pain medicine. I do recommend to check the resources of patients section at the American Academy of Pain Medicine, or painmed.org, and go and check out all the information materials about different treatment modalities, evidence-based medicine, and alternative treatments for pain.